Good afternoon. On behalf of AMDA and the D2D initiative team, we welcome you to our September check-in and progress update. I'm Sabine von Preis-Friedman, one of the co-chairs, your host. The goal of our check-ins are to activate the power of our community. We all know that polypharmacy contributes to poor outcomes and quality of life of our patients. As a community, we have made the commitment to medication optimization and a goal of 25% reduction of polypharmacy. Here's what we've covered so far. We've covered building the deprescribing team. We've developed your deprescribing intervention and process, and we reviewed deprescribing algorithms for the following medications so far: proton pump inhibitors, vitamins, and anti-hyperglycemics. Last check-in, we had a great presentation on communication techniques by our member, Jennifer Brukowski. This meeting is all about the front lines. How are we translating what we have learned, the evidence and the guidelines into action? The actual implementation, we have the knowledge, but how do we get it done? The strategies, what works well for you, and what are we still struggling with? What insights do you have that you can help us with? Please contribute to this discussion. Our entire process will be richer for it. The process for today's section is basically, we want you to participate. Use the chat function during the formal presentation, and then feel free to unmute yourself as well. The session will be recorded and slides will be available later. Our D2D team will be actively monitoring the chat and responding to your questions with references or their own insights. So there will be a whole other conversation usually going on in parallel. What are we going to do today? We're going to discuss the role of the NP team members and identify optimal ways of collaboration and deprescribing. During our last check-in, we heard from a medical director, and today we are looking forward to be hearing from a nurse practitioner. As the year goes on, we are planning to have other deprescribing members relate their best practices and successful strategy. We will then close out the session by having Michael Sinqui demonstrate on how to use data to drive and make progress in deprescribing. In short, our goal is that all of you can take away at least one action item that you can immediately use to drive the deprescribing process yourself. With that, without further ado, we're going to go right to the field, and we are lucky today to have nurse practitioner Brandy Botello join us. Arif and Brandy, please take the floor.
Oh, happy to. Thank you so much for this excellent introduction, Sabina, and just reminding us where we have come in this journey, which is still quite early in its, the whole process of, of the deprescribing initiative. So we're still early days here. And as we promised before, guys, that we are not the experts. We are just the cheerleaders. We are pushing this bandwagon forward, but it's the people on the front line who really are doing the hard work already and are going to be contributing a lot to this campaign. Now, we do hope that this campaign will lead to creating a whole new level of cheerleaders in the field, but we know that there's many of you who have already been working towards this very important approach to care already in your day-to-day work. And in my day-to-day conversations in my own organization at Signature Healthcare, I've been lucky that since we have kicked off this campaign, I've also found out that we have many experts in the field in many disciplines. It's not just an initiative where a physician can put a cape behind and then do the whole work by themselves. We really need team members to be engaged in this. And I'm realizing in my day-to-day work in my organization, and I bet you will do this, be recognizing the same thing, that there are many leaders, champions who have been engaged in this process and who have some excellent tips and experiences that can make us all better in providing good care. So in my day-to-day exploration, my work in my own facilities, I was able to, very lucky to have a conversation with Brandy Rotello, how she, as a nurse practitioner in one of our facilities, has been doing some amazing work, and how she has felt energized with the day-to-day campaign. So with that, I would like to say welcome to Brandy. Brandy, if you can unmute your mic. And we're also hoping that Amy Keller, who's a partner to Brandy in that facility, as another team member, as a nurse partner in that care team, would be able to join us too. So with that, let me bring Brandy in. And Brandy, if you can do your introduction, and we'll kick off with some questions and get some insights from you.
Sure. Thank you, Dr. Nazir. I was just going to share a few things that we've implemented in our building, been working on to try to improve our polypharmacy and deprescribing efforts.
And Brandy, before you kick off, can you just tell us a little bit about yourself, how long you've been a practitioner and how long you've been in this facility, and just tell a little bit about your facility. That would be great.
Sure.
Thanks.
Sure. I am working in Washington Rehab and Nursing Center in the Panhandle of Florida. I have been a nurse practitioner for 3 years, and this job was my first job as a nurse practitioner. Graduated from the University of South Alabama with my family nurse practitioner and adult acute care.
Great, thank you.
Going forward about, kind of some things that we've been doing in our facility. First, I want to say that I don't think that appropriate medication management is not something that you can just look at one time a year. It's not something that you can even look at, every 6 months. It has to be something that is done every time you see the patient. And medication review, not just specifically seeing what medications the patient is on, but specifically looking for medications that they may not need that can be deprescribed. I have Amy Keller with me. She's one of our aid-ons. She specifically takes care of our rehab hall. And she's going to tell you a little bit about our admissions process for the medication review.
Oh, wow. I was really hoping and praying that we'll have one of our nurse leaders joining, and you were able to join, Amy. And I cannot thank you enough, because I know how busy you are at the front line. So if you could just introduce yourself a little bit about your experience and your practice at nursing homes, and then we would love to hear your perspective on deprescribing and how do you partner with Brandy. Thanks.
Okay, I'm Amy Keller. I am an aid-on here at Washington Rehab. I have been in long-term care for about 25 years. I have been with Signature going on 13 years. And what we're doing now is on admissions, we look at the residents' medications prior to their hospitalizations, and we are comparing it to their hospital discharge medication list. We're trying to talk to their families and go over the meds that they were on prior to the admission to the facility, and discuss the new meds that were added while the resident was in the hospital, and ensure that they have appropriate diagnoses for all of the medicines. Once this is done, all the medicines are reviewed with the doctor or nurse practitioner, and at that time we're able to make changes that's needed. And specifically, we're trying to target the PRN medications and the PPIs. These seem to be the medicines that usually are specific to the hospital needs and not usually appropriate once the patient is stable enough to be discharged back to us.
Yeah, that's very helpful. And Brandy, when I talked to you a little bit earlier, you also mentioned that you also have a process around your long stay patients, how you kind of look at optimization and deprescribing for that population.
Right. So long-term medication lists are long-term residents. The medicines are reviewed each visit. Specifically, we've been trying to target vitamins, supplements, unless they're specifically treating an obvious deficiency. PPIs, especially if have been used greater than a couple of months, and especially if the patient doesn't have a history of a GI bleed. Also Novalogs with the sliding scale, once their AccuChecks are good and controlled, the Novalog's not needed. There's no use to keep it on the MAR and keep ordering it. and then PRN medications. Had several patients that just had an order for a nitroglycerin sublingual PRN that they never used. So we started getting rid of those medications. PRN medications are also always available in the emergency kit, you know, if you need for an acute illness. I also try to put a stop date on any PRN medications that are appropriate to the illness that we're treating. You know, if you and I have a stomach bug, we don't need Zofran for 7 to 14 days. You know, usually 24 to 48 hours, unless you've really got a bad bug, is sufficient. So the limited, you know, time that those medications are on the list, the less chance of medication interactions and less chance of side effects.
Well, I thought that PPIs need to be used for 17 years at least. Isn't that true?
Some people would say so.
No, thank you. So thank you for that. And also in our earlier conversation, you talked something about family because, and you know, engaging the family members, and because that's an important element which we heard a lot about from our audience the last time when we were presenting, is that sometimes family members can be a barrier to deprescribing and optimization. What's your thoughts on that? How do you approach that?
I feel that a lot of family members are open to it, especially when you kind of go at and really educate on the risks versus benefits of a medication. The ones that are more hesitant, I kind of take a slower approach and say, you know, if you can talk them into, hey, let's just decrease this medication back to once a day. Or let's go to PRN and see if you actually need this medication. And sometimes taking a little bit slower approach helps to make them more comfortable. They feel like their opinion is appreciated too, you know, and that they have a little bit of control as well in their healthcare.
That's amazing. And we'll talk a little bit more about this aspect. But I really want to get to something you mentioned very interesting earlier on, was that since you've been focused on medication and D2D itself, you have seen a change in your an evolution of your relationship with your nurse partners, and they are kind of reaching out to you also about this issue. Can you talk a little bit about that? Because I really found that to be very interesting.
Yes, I love our nurses here, especially, you know, the ones that have been here for a while, have the same cart, the same patients. They usually know that patient in and out. They know their medications in and out. And once I started explaining, you know, coming to them, if I deprescribe a medication, I try to sit down with that nurse and say, this is why I did this. You know, this is what I was looking at. These are the parameters I use. And they did. The nurses started coming to me and saying, hey, you know what we did with Mr. Smith? Well, you know, Mr. Jones, he's having the same issue, or he's got a similar medication profile. You know, what do you think about taking him off of this medicine? They really responded well, and you know, I think nurses are just amazing, and they want to learn and, you know, want to improve their patients. So
wow, I think what you're touching upon is so important, that, you know, the one benefit of working in teams like that and creating partnership like you have created, it kind of spurs on the good practices, right? I mean, you kind of ignite basically a fire of something positive and quality improvement, and other people start seeing the benefit, and then they start coming to you like, hey, whatever you did that other hall, I want you to do that on this hall too. Can you teach me? Can we talk about it? So I think that's just an amazing role model approach you have taken here. And I'm sure Amy kind of is being a role model for other nurses, particularly the younger and newer nurses who are joining also in that. So thank you for sharing that strategy. And then lastly, I just want to talk a little bit about, have you started seeing any impact or benefits of the D2D campaign or the approaches you have been using around optimization and deprescribing of medications?
I think that this D2D campaign is amazing. I think that healthcare as a whole, we kind of got into this role of, we weren't treating a patient unless we were giving a medication. And then patients in turn started thinking, well, they didn't do anything for me. He didn't give me anything, you know? So I think that this campaign to kind of change the mindset and help with, you know, kind of less is more, you know, mentality. I think it's just amazing and awesome, and excited to see where this goes.
Now, I know that we have at Signature kind of used the D2D campaign to build our own internal competition called Siggy 500. And we're going to be talking about that in the later calls. But are you energized and are you ready to win that competition?
Yes, very much so. We are ready. Are we? Yes. Yes.
I mean, having Amy and you on the team, I'm sure like Washington is blessed and has a very good chance of being on top of that competition. But guys, thank you so much for all you're doing as partners in improving patient care and focusing on the right things in geriatric care. We can't thank you enough for all the work you do. And thank you for taking a few minutes of your time to educate 110 people on the call here representing many, many facilities. So your message is going to go far tonight. Thank you so much. We really appreciate it.
Hey, thank you, first of all, for this fabulous, your fabulous insights. I think you made a lot of important points. I want to talk a little bit more about the discontinuation of PRNs. I think that is something that we can all benefit from, and most importantly, patients also benefit from, because of my experience, when a PRN hangs around too long, it seduces maybe a nurse who's not so familiar with a patient to use that PRN in the case of a change in condition. That's why I try to, in my practice, to try to keep that at a minimum. Tell me, which PRNs are high on your list that you discontinue? You mentioned nitroglycerin. Anything else that you discontinue quite often?
Tylenol, anti-anxiety medications, anything that may have an underlying condition that needs to be treated. Essentially, if you're using routine PRN medications long-term, then something's not effectively being treated.
Mm-hmm.
So our anti-anxieties, the nitroglycerins, the antiemetics, Tylenol.
Antiemetic, I like that. The Zofran, everybody comes in with a Zofran, don't they?
Yes, from the hospital, yes.
And how do you make your decision there? So, I think, I don't know whether we have any hospitalists here on the call today, but I think this is like the discharge, you can pretty much check off. There's always Tylenol. There's always Zofran. There probably is a PPI. How do you make the decision whether you, and sometimes people are actually taking it, sometimes they're not. How do you make that decision whether you discontinue that?
So if they're coming from the hospital setting, that's what you mean? Good review of the hospital records. Are they post-surgery? How far out post-surgery are they? We shouldn't still be having some nausea from that. What was their underlying diagnosis in the hospital? And then just initial assessment of the patient. If it's something I'm not sure about, if they have a diagnosis from the hospital that may still require an antiemetic, sometimes you just have to see the patient first and just kind of assess their symptoms and, their needs, and just kind of go forward from there.
Okay. Well, assessing the symptoms does work, doesn't it? It's like the one-on-one. I'd love to know from the audience. So audience, please participate. Which ones are the PRN medications that you either discontinue regularly, or which ones are the ones that you have questions about, whether you should or should not discontinue PRN medications? So please let us know what your thoughts are on that. And I also have another question, and that's mainly to Amy, but can be to both of you. Have you been able to be, obviously you two are doing a great job, and probably everybody here who's on the call is doing a good job being aware. But what I'm always interested in is, how can we, and have you been successful in that? How can we integrate the deprescribing into the workflow so that when one of us is on vacation for 4 weeks, which I know never happens, but that it still works? What have you been doing in that regard, and are you successful in that?
With the new admissions that are coming in from the hospital, we actually have the med reconciliation form that we fill out, and pretty much it covers step by step how we're addressing the, reducing the meds, down to where we actually have to, call the doctor or, discuss it with Brandy. And we fill that out, and then we have to actually make a progress note from start to finish where we've called, and we have to list all of the medicines that were discussed and any changes that were made, and that the resident and the family have been notified of the changes.
So you have a form.
Mm-hmm.
And you introduce, and that form has a place in the admissions process. Is that correct?
Yes.
Well, that's brilliant. I have not heard that before. So would you be willing to, the question then is, would you be willing to share this form? I think Arif probably has a last say on that one, or something like that. Because I think we can maybe publish it, or at least publish the idea on our D2D landing page.
Yeah, we'll be happy to share any resources which can help anyone. Absolutely, that's the purpose of this community.
Yeah,
for sure.
So I see a lot of comments here. Thank you. I see Dr. Schmitz is on. That's great. He's my partner in crime in one of my facility. But antiemetics, low-dose psychotropics, PRN benzos. What do you think, Michael or Chad? PRN benzos discontinuing right away on admission or not?
I would think that yes, after you've done your assessment and you get a sense of where the patient is, that discontinuing them is appropriate. Remember, they're in your emergency card or OmniCell or whatever you have. They're right there if you need them. So it is a good idea if you assess that it's not an issue to take them out.
And see, you are in a real working environment. Hello. So thank you so much for joining us here. Some other, Steve Levinson, hello. Thank you for giving us the buzzword opioids. I think that will be a whole D2D session. I think that is extremely important. What is the most important thing that you hope we take away from your experience? The one thing that everybody can do.
I think just persistence and consistency of those medication reviews. It's not something that's going to happen. It's going to, it's going to be an ongoing, something that you just have to keep working at.
It's not a one and done, isn't it? And I think you as a nurse practitioner collaborator are just so important. Penny Logan says, never give up. So there you go, never give up. I have to tell you that I particularly like your approach with hesitant, I'm using that word a lot these days, hesitant family members and patients. I think that is something that I am taking away. Give them control, change it to PRN, do it GDR instead of taking something away. I love that approach, and I think that is something that we all can take away today if we have patients that are hesitant to follow the recommendations because they've been on a medication for so very long. I personally, by the way, always do a GDR on PPIs that people have been on for a long time because I find that is just a better way to deprescribe. So thank you so much. And we're going to move on here, and I'm going to share my screen again. And we will now go to Michael Sinquil. Michael, I'm going to prep the screen here. Okay. So we are so pleased to have D2D Initiative Pharmacy Collaborator Michael Sinquil with us today. Michael is a Senior VP for Pharmacy Management at Genesis, and he will give us some examples on how to use data to improve policy.
Well, good afternoon, everyone. I think the message here is going to be that this doesn't have to be complicated using data. It can be really simple with what you have access to. So the first slide, the first example I want to give you, and I'm going to give you two. So the next slide, please. The next slide was how one of our centers attacked multivitamins. And I wanted to share the strategy with you because it's so simple. They went into their EMR, we use PCC, and you can use whatever you want. All EMRs are going to have some source to be able to run your patients who are on multivitamins, and they targeted residents on multivitamins. And it was, their criteria was super simple. They were going to evaluate and discontinue multivitamins, get this, in residents who eat well, right? Because that pretty much is, we should, if there are no bloods or anything else that's going on and they're eating well, there's really no reason for an MVI. But you know, these things get started and they go on. So just looking at how people are eating will help you with your multivite conversation. This particular initiative was brought up by a medical director who then ran it through the clinical team. Next example, please. So the next example is on proton pump inhibitors. And this data, the source of this data is pharmacy data. Now we happen to use Omnicare, but all of you all have access to something like this. And so this is PPIs over a year, and you can see that this particular center, it was pretty high. And then in December, they did an intervention, and wow, what a great improvement. But then look, it started to go back up again. I'm thinking COVID had something to do with that, but okay. So it started to go back up again. And then we started with D2D. We really started talking about deprescribing, polypharmacy, and they made an intervention in August. And look, that's what happened. And so again, this is an example where using the data that you have can do a couple of things. It can show you where you need to act. It can show you, are you on track? But here's the key. It'll show you if you're staying on track, right? So they fixed it and then it slid, right? So one of the messages I want us to really think about with our data is that these interventions that we make, they go on forever. And we will need to constantly reevaluate how we're using our data for our interventions for our patients. This intervention was started by a director of nursing with a medical director, the consultant pharmacist, and the nurse practitioner. And that was that team. And so the message there is you'll have different drivers in your centers. There's no one sort of equation for a successful team. It's going to vary based on what you have. So next slide, please. And then finally, really what I want you to come away with is that improvement happens where the care happens. So, you know, these two initiatives were done at the center level by the centers. Corporate had nothing to do with these. They did this on their own. Interventions are forever when discipline occurs. That's the key. And remember that PPI slide. It was really high. They crushed it, and then it started to creep back. And they hit it again. So that's where the discipline comes in. Keep in mind that what you're doing here by using your data and making these innovations, and Brandy was all over it, is you're creating a process, you're creating a discipline to be consistent as you approach these. And anyone can be a leader here. Please, if you have examples, send them to us. Maybe you'll present them, maybe we'll present them for you, whatever you want, but we would love to hear we'd love to see how you're doing well and having success pushing back against polypharmacy. Thank you.
Thank you, Michael. I love to see data, and I think data can help us in so many ways. And yeah, and unfortunately, they sometimes show us that we are sliding back. So I think this is, in many ways, this was a really good, reminder as well. We recently did a survey, and the survey showed, among all of you, thank you to those who answered the survey, we came up with a couple of things. One was the still hesitant family members, and I think Brandy has just done a great job of a practical approach. And then the other one was administrative buy-in is not where it ought to be. And having been a medical director for decades, I know in fact nothing really gets done to its optimal unless the administrator is involved. So how can you maybe use data to get your administrator more involved in the process?
You know what, that is such a very important point. And I think the way I would approach that is every member of the care team, which the administrator is a part of, has their own area of emphasis. And, you know, when I think of administrators, I think of their primary responsibility of, you know, it's occupancy, it's people in beds, it's the growth of the center, right? It's keeping the beds full. And you know what? When you focus on polypharmacy and you focus on the evidence that shows that as the number of RXs per patient drop, the negative outcomes, the falls, the hospitalizations, these things drop too. So if you target it that way, and you're reaching out and describing against the things that an administrator is really focused on, there's plenty in here with what we're doing that an administrator could really buy into and see, I should support this. This will help my overall performance and my overall actually center performance.
And Sabina, can I add to what Michael's comment there? I'll tell you that the D2D campaign, which is now at Signature, is being paralleled by our own internal campaign, and we're trying to take step forward along with the D2D recommendations. It has energized our conversation around staff time, particularly in these times when we have had more than 300,000 people who have left the setting since the pandemic. This has become a go-to strategy for our operational team and administrators in the DON. It has given some reasonable life to the conversation. How do we solve the staffing issue? It has energized everyone that, you know what, maybe we can save a lot of time from the staff if they don't have to give unnecessary pills. So really D2D has energized this conversation, at least in my organization. So I think other than what Michael shared, I just want to share that nothing is more important at this point to administrators than to how can they get enough care delivered to the patients, which is deserved. And I think deprescribing is one of those strategies which provide nurses more time to spend with their patients.
Great.
Yeah, I think it is really important that we give a benefit statement. And I think we identified two important benefits. By the way, one is, you know, reduction of poor outcomes, hospitalizations, then reduction of staffing time around medication management. And a third one, and that's always important, is really also potentially reduction in costs. In one of our regions, we have demonstrated, one of our groups who is in one of our regions in Oregon, we demonstrated a $1 per person per day reduction in medication costs in post-acute patients with an aggressive deprescribing program. And that is quite a bit of money as well. And money well saved because it actually improves patient care. So that's where I love to argue and make my point also with administrators and operators.
And Dr. Dan Hamowitz is taking the conversation very appropriately, like how do you present data to physicians and other people, prescribers. And I think Sabina, you did a great job of showing some sample slides from your organization, and we will be presenting soon the work we are doing with PharMerica's help to create physician level, facility level metrics. And the two metrics we are sharing, I see that some of PharMerica data gurus are on the call. Hey, Steve, we are building reports where buildings will get two very important reports. Just a sneak peek here, and we'll be presenting some of those in the future calls. One is going to be to show the buildings how far they have come in deprescribing appropriately over the last few months. So really showing them the trends overall, but also medicine specific, category specific. And then we'll also be showing them monthly change or movement they have made, like 1% decrease since last month and so forth. And the second report is going to be who are the patients, which Sabina is going to love because we stole our strategy there, that who are the people who are taking more than 9, 12, 15 pills. So that gives people right away, hey, here's your high list, high priority residents you should be going after right away, because among them, you may find people who may be at a brink of having some harmful effect from that many pills and so forth. So those are the two reports we are focusing on. And I think they will be very, very, very helpful to frontline clinicians and physicians and so forth.
Well, thank you, Ari, for that insight. I can tell you data will really help you here as well, Dan. So the way I work with attending physician is giving them information and giving them data. And so we have a lot of information on the D2D website. Please utilize that. We have a sample letter that you can also use. But then give them data. And actually, we have a data point on our medical director scorecard. And that's medication, over 18 medication. That's really hyperpolypharmacy, right? And we have that, and those are the patients that we first should look at. And giving that information to the physicians would be good. And then also, what I have employed as a strategy before is make that a public, semi-public QAPI data point. So which physician has, I don't know, 20% over 18, which physician has 5%, and make that a little bit of a competition, just like the Ziggy 500 in between centers. You can also do that on a micro level and do it with physicians. All really respectfully and always coupled with evidence and information and support, for sure.
I do want to highlight a couple of comments here. Zed has, I think Ziad Mirza has shared with us a very important point that we do struggle because we have lack of data for patients in for population nursing homes. So that's always going to be struggle in any intervention, is that we just do not have all the research we need. So we do extrapolate a lot of research based on studies on the outpatient side and so forth. But he highlights that we definitely need, so researchers on the call here, we have our work cut out for us to really be needing some high quality research on what really, do multivitamins help in this population? And do PP, what's the adequate timing for use for PPIs, for example? Is it 6 weeks? Is it 12 weeks and so forth? So we definitely are handicapped because we just do not have the research, and that's a hurdle we have. And Michael, I think there's a question for you.
So there was a question about the PPI reduction that happened in the center that I presented, and the question is, was it about PPI reduction? Was there de-escalation? Did we use the Canadian guidelines? And the answer is yes to all of the above. It was a PPI reduction program, but de-escalation was a part of the program. And yes, the Canadian deprescribing.org references are used also, and they are awesome. If you've not seen them, they are on our D2D website for PPIs and others. If you don't have access to them, we do.
And Arif, I agree with you. There is evidence in our space is often not direct and it needs to be extrapolated, but there is some evidence, there is some evidence in overprescribing of antibiotics for UTIs that doesn't help. There is evidence that polypharmacy actually leads to falls, polypharmacy leads to hospitalization in our space. So we have some evidence.
No, absolutely. That's why we have this campaign, because we know that we're on the right path. based on
So-
that evidence, but we do need some specific evidence on specific medication and so forth. But I fully agree with you. We have
Yeah.
enough evidence to be having initiatives like this.
So I don't want to cut this from out from under us. I think we do have plenty of evidence how polypharmacy can hurt our patients, and we are here to refine how to best approach it. And we are almost out of time now. And I really want to thank everyone for the active discussion that has been going on. I want to highlight a few other things that was in here. Steve Levinson just did a shout out also for the new AMDA pain guidelines. They will either are out already or will be coming out already. Please have a look at opioid reduction in these pain guidelines. Lots of smart people have put a lot of energy into that. And I think that's something that is yet another tool for you that you can use. And not only that, if you have it in the AMDA guidelines that are so well respected, it is also, just a very reputable source that you can, it gives you backup for your interventions. So I think that's just something that I want to mention.
And Sabina, I do wanna invite people who are on the call to be presenters for the next office hours.
Yes.
We really want to hear from you, and we want it to be interprofessional. So please, if you have you and your team members who are doing some great work, we need your tips. We need your ideas.
Yes. So with that, I want to thank Brandy again for, I think, a very thoughtful and thorough and very effective approach. I have learned much today, and this is what I've learned. Deprescribing, or maybe I knew it already, but it's so well said. Deprescribing starts on admission. I think that is absolutely profound and true. Do stop dates on PRNs. Do it however you want it, but do it. And as a medical director, educate your staff and maybe do some policies and procedures around it.
And Sabina, I learned that deprescribing starts at admission and continues at every single visit.
Yes, good addition. Yes.
Thanks to Brandy and
It's-
Amy.
Yes, and look at your data to make sure you're not slacking off. I loved also the third golden teaching point for me today was how to empower hesitant families to continue to make good choices by only do gradual dose reduction or switch to PRN and then evaluate. So I think those are some great take-home points. We will continue to provide you with evidence and tools for deprescribing. Here again are our D2D resources. Please take advantage of them. And our next D2D webinar is October 21st. And our next progress update is November 18th. We hope to see you all there. Thank you all so much for what you do. Feel free to touch base with us in between with all the tips and tricks and success stories. And maybe if you have a barrier, see whether you can help us. So thank you very much again. And we will all see you soon. Continue to deprescribe and optimize our patients' medication. Bye-bye.
Thank you.
Thank you.